Tenosynovitis. Okay. Some relevant legend or literature I want to show you so that you will never forget. Canaval sign is seen in Tenosynovitis. Okay. Tenosynovitis. First, you see about the anatomy. Anatomy, 90% of the times, you see the tendon covered by tenosynovium. In second, third, fourth are limited only to the fingers. They do not have extended bursa. For the first, that is for the thumb and the little finger, the tenosynovium is connected with the ulnar bursa and the radial bursa. I hope you can see me on the slide, right? So,
Yes, sir.
whenever the infections of thumb and infections of tenosynovium of flexor tendon of thumb and little finger are dangerous because it can extend into up to the wrist because they are connected to ulnar bursa and radial bursa respectively. Okay, so this is a brief anatomy about the tenosynovium of flexor tendons. Okay, please remember this. And how do you identify them? Whenever the patient comes with pain in particular finger with no history of trauma, you will have swelling of that thumb. It is generally a sausage shaped digit or banana shape to make it more simple. So you will have tenderness at the flexor tendon, pain in passive extension, and the patient keeps the finger in always flexed posture. These are Canaval's cardinal signs of tenosynovitis of flexor tendon. Please remember this. Tenosynovitis of flexor tendon. So the Canaval sign is positive in tenosynovitis. Carpal tunnel syndrome is totally a different. Dupuytren's contracture is different. Trigger finger is something different. I will try and highlight for you to understand what is trigger finger. Trigger finger is you develop a nodule here. There is because of a nodule in a tendon. So whenever it gets inside because of the movement, the finger gets stuck. So it releases by a passive extension like a trigger of a gun or a rifle. That is a trigger finger. Can you see this? Can you see my marking?
Yes, sir.
Guys, please respond. Otherwise, I'll not be able to understand whether you are able to catch up. Okay. Okay. There is a small nodule here in a flexor tendon which gets stuck in the tendon sheath. You understand? There is a tendon covered by a tendon sheath. So it gets stuck at the mouth of the tendon sheath. Again, the tendon sheath, I will explain the relevant anatomy of the tendon sheath. You have pulleys. You have pulleys for the flexor tendon sheath. So these are C pulleys and A pulleys. Please remember this. A pulleys are annular pulleys and C pulleys are cruciform pulleys. Okay, cruciform pulleys are like this in the form of cross, and they generally are across the joint C1, C2, C3. Okay, in between you get annular pulleys. Annular is nothing but ring. Please remember, annulus is nothing but ring. They are having like this. Most important pulley is at the MCP joint. That is A2 pulley. A2. Please remember this. You might get somewhere else. Okay. This in respect to trigger finger I was mentioning. Carpal tunnel syndrome, you know very well. It presents with a compression of the median nerve. Dupuytren's contracture is nothing but there is a fibrous sheath here, which with all the fingers try to be in flexion. These are all chronic diseases. Tenosynovitis is a acute condition. Okay. Infection of ulnar bursa is again diagnosed by. Please remember, this is nothing but a kind of Ulnar bursa, as I said, it is a part of a tendon tenosynovial sheath. The answer is again canaval sign. Okay. So synovial tenosynovitis of flexor tendon. What is the correct option? The affected finger is extended in at all joints. Little finger infection can spread to thumb, not up to index. It has to be treated conservatively. Patient present with minimal pain. Can anybody answer this? Having detailed about in this previous slide, I guess most of you can answer this. What is the correct option for tenosynovitis of flexor tendon? Anybody, any one person, so that I'll proceed. Please go through the options.
The little finger infection can be spread into thumb, sir.
No, yes, that is because your ulnar bursa in the little finger and radial bursa in thumb get communicated. This you will develop something called as horseshoe abscess or horseshoe abscess, because it looks like a horseshoe. Okay, you cannot treat conservatively because it is a pus. You have to drain it. Patient present with minimal pain, wrong. And affected finger is in flexion, not in extension. Very good. Who was that?
Sir, Roshan, sir.
Well,
Roshan, sir.
okay, good, Roshan. Most common. Who is this? Okay, forget it. Most common finger infected with Felon. Thumb, index, ring, middle, and thumb more common than index finger.
Sir, thumb is more common than index finger, sir.
Yes. So what is Felon? What is Felon? Felon is infection of the pulp of the finger. You remember infection of the pulp of the finger, tip of the finger. And there is a difference between Felon and paronychia. Okay. So Felon is infection of the pulp of the digit. It can be thumb in any of the fingers. So thumb is more common than index. So what happens in Felon? This one here ends your flexor digitorum profundus. Here ends your extensor indicis. So beyond that, the finger pulp or pad is divided into tight compartment because of fibrous septae. There is a small fat pads which are very essential for your touch. So if these gets infected, it is called as Felon. Understand?
Yes, sir.
So Felon is infection of nail fold, infection of ulnar bursa, infection of DIP joint, infection of the pulp space. It's a no-brainer. Anybody can answer? Answer is?
Pulp space.
Very good. Okay. Felon most common complication is?
Sir, osteomyelitis, sir.
Very good. Very good. I did not go much into that. So index finger infection spreads too. I was talking about the spaces. These are your flexor tendons, and this is ulnar bursa. So hand space infection is very, very important. Index finger infection, does it spread to thenar, mid palmar space, or a flexion space? Certainly not thenar, because it spreads from the thumb, radial bursa. Okay. Hypothenar space, no. Mid palmar space, yes. So correct statement about hand infection. Opening of Felon by fish mouth incision is a preferred incision technique. Apical subungual infection, V-shaped teeth is removed from. These questions I have taken from previous papers only. It is nothing that they are something very difficult. They are bound to reappear possibly. Felon is a middle volar pulp infection. When the pus extends beneath the nail, it is necessary to remove some part of the nail, adequate drainage. Felon is the most common infection of the hand. So you can have more than one statement being correct. Okay.
Yes,
So
sir.
Felon is a common infection of the hand is correct answer. When pus extends beneath the nail, you have to remove part of the nail because to avoid the nail bed damage, your nail can always regrow. Some amount of or partial nail removal or total nail removal is essential depending upon the extent of the pus under the nail. So as to avoid the nail bed damage, nail can always regrow. Most common site of actinomycosis among the following. Can anybody tell me? It is always mandible. In actinomycosis of the spine, the abscess usually erodes into pleural cavity. I have not prepared much diagrams for this. Anyway, a swelling with a patient with swelling of foot, pus discharge, multiple sinuses, KOH smear shows filamentous structures. It's a repeat question. I think it appears very, very frequently.
Osteomyelitis.
Osteomyelitis, sir.
No. KOH preparation means invariably it is a maduromycosis or actinomycosis. Filamentous structure. KOH preparation is always for fungal elements.
Oh, sorry.
Yes, sir.
Actinomycosis. Chondrolysis occurs commonly in TB arthritis, chondrosarcoma, syphilitic arthritis, septic arthritis of infancy. Read the question properly. When you do not know the exact answer, you can always attempt by ruling out the options. Chondrolysis is nothing but lysis of the cartilage, isn't it?
Yes.
So certainly chondrosarcoma is gone. Tubercular arthritis, syphilitic arthritis. Septic arthritis of infancy, where the femoral head is unossified and totally cartilaginous. Infancy is less than 1 year and your femoral capital epiphysis appears at the age of 1 year. So if the femoral capital epiphysis is not seen in X-ray, radiological age of the child is less than 1 year, and if there is a septic arthritis in that age, the entire capital femoral head gets destroyed. That is one of the cause that is also called as Tom Smith arthritis. We'll come to that later. Most common cause of bony ankylosis. So bony ankylosis, you know, any arthritis for that matter, ends untreated or neglected, can end up with bony fusion. Okay. So there are two types of arthritis. Ankylosis. Ankylosis is nothing but there is loss of movement of the joint. So it can be, ankylosis can be bony or fibrous. Please remember this. This is very important. So what we want is, what is the common cause for bony ankylosis? Rheumatoid arthritis and osteoarthritis are, one is age related, or one is age related arthritis, where please remember osteoarthritis is again a misnomer. It is osteoarthrosis. It is a degenerative disease. Rheumatoid arthritis is an inflammatory disease. So these both cannot cause ankylosis. Now the remaining options are tubercular arthritis and pyogenic arthritis. Bony ankylosis happens when, I'll draw a picture of the knee, where the entire cartilage is eaten away or completely eroded. Then when subchondral bone comes in contact or rubs each other, you get a solid bony ankylosis. That is possible because of high virulence of pyogenic or bacterial infection. So pyogenic arthritis most commonly leads to bony ankylosis. Even in tubercular arthritis, there is loss of the articular cartilage, but it causes fibrous ankylosis. You can short remember with some kind of mnemonic. Tubercular arthritis causes fibrous ankylosis. Pyogenic arthritis causes bony ankylosis. Mind you, when not treated adequately or when not treated in time. Tom Smith arthritis. So what is Tom Smith arthritis? Increased hip, how does it present? It presents with hip mobility and very unstable hip, ankylosis or stiffness or lengthening of the limb. Can anybody take a chance? Okay, going on what we discussed earlier, where the chondrolysis is seen in pyogenic arthritis in infancy, isn't it? We ended up understanding that. So when you can see a picture here, this part on this side is totally eaten away. The femoral capital epiphysis is totally eaten away. When this is eaten away, when there is a large joint space, what happens? There is a flail limb, unstable limb, excessively mobile limb. So increased hip mobility and stability. Tom Smith arthritis manifests as unstable hip or excessively mobile hip. Hip stiffness is not there. Ankylosis, as I said, it is only in adults. Lengthening of limb, of course, is not possible in Tom Smith arthritis. Transient synovitis of a hip is characterized by all except. So transient synovitis is one entity in orthopedics most commonly affecting hip joint, and it is generally diagnosed in retrospect. Patient comes with hip pain, treated symptomatically, no antibiotics, just rest and analgesics. The transient synovitis disappears within 3 weeks. That is the reason why it is called as transient synovitis. So it is non-infective. We don't treat them with any antibiotics. Rest and analgesics, the synovitis disappears. Any hip, for that matter, arthritis of any joint starts with a synovitis, ends up with arthritis. But if you treat adequately, you might halt in synovitis. Treat adequately. I mean, synovitis can be transient, tubercular, or pyogenic. But even without any specific treatment, synovitis resolves, becomes normal. It is transient synovitis. Please remember this. So what are the statements which are true? All are true except may follow upper respiratory infection. Ultrasound of the joint reveals widening of the joint space. ESR and white blood cells are usually normal. Hip is typically held in adduction and internal rotation. So one more important thing I want to tell you here, hip is not held in adduction, internal rotation. Any, for that matter, effusion in the joint increases the volume of the joint. So it is like inflating a balloon. So once it is inflated, hip goes in abduction, external rotation, and flexion. I think you must be knowing this. So hip goes in abduction, external rotation and flexion. This is a position of the limb where you get maximum volume for the hip joint. Any synovitis, whether it is transient synovitis or synovitis of any cause. So hip is typically held in adduction and internal rotation is wrong. 7-year-old boy with abrupt onset of hip with hip held in abduction. Hemogram is normal. ESR is raised. What is the next line of management? Mind you, he is a child. Suddenly he comes with abrupt onset of pain held in abduction. It indicates that there is some amount of collection. ESR is normal, means there is no infection. What is the next line of management? Antibiotics is ruled out. Ambulatory observation is out of question because you might be further damaging. Hospitalize and observe, or USG guided aspiration of the hip.
USG guided aspiration.
Yes, USG guided hip aspiration is very, very important because whatever synovitis you are suspecting can be infective. So what you have to do, you have to aspirate. Of course, you have to admit, aspirate and send it for gram stain and culture and sensitivity. So if you rule out infection, it will become a transient synovitis. If there is a evidence of neutrophilia and organisms you grow, then it is a early arthritis. So USG guided hip aspiration is what you have to rule out to you. It is the investigation of choice when the patient comes with this above complaints. So 7-year-old male complains of fever and pain in right hip. On examination, he has swelling in right hip region, flexion, abduction, external rotation. This is a typical attitude what I was mentioning earlier. Mild reduction in the movement. On X-ray, there is an increased joint space. The diagnosis is
Transient synovitis.
very good. So, in any arthritis for that matter, it is flexion, adduction, internal rotation. But if it is synovitis with lot of effusion, it is flexion, abduction, external. Flexion, abduction, and external rotation. Dislocation of the hip, certainly not the answer. 4-year-old male complains of high-grade fever, decreased appetite, pain in the hip. On examination, he has dehydration. There is swelling in the right hip, flexion, abduction, external rotation. Hip movements are absent. X-ray, there is a mild increase in the joint space. Of course, I think it's a different clinical picture what is being given. But again, the answer is, remember this, whether you want to go for this or go for this answer. Anybody? Definitely, there is flexion, abduction. Yes.
Sir, in septic arthritis, that is absent of movement of joint.
It is there even in transient synovitis also. What is more important is high grade fever, decreased appetite. This indicates what?
Septic arthritis, sir.
Yes. Very good. So you have to read the question properly. Don't jump to the conclusion. The child will not be toxic or will not have fever and other constitutional symptoms in transient synovitis. So septic arthritis is diagnosed by, I think you can take this.
Sir.
Anybody can answer me?
Sir, X-ray, sir.
No.
X-ray with aspiration, sir.
Joint aspiration.
Yes, joint aspiration. See, if MRI will show you synovial fluid collection, ultrasound also they will show you synovial effusion. It will be normal, but to prove that it is infective, you have to aspirate and culture. Tissue diagnosis is the ultimate court of justice in infection and malignancy. Please remember this. Tissue diagnosis only is a final court of law for diagnosing infection and malignancy. Deformity in synovitis of the hip. Anybody can answer this? Hello? Are you
Sir,
there?
all of the above, sir.
All of the
Very good. Very good. We'll not waste time on that. Aspirated synovial fluid in septic arthritis will have. Remember this.
Sir, marked increased polymorphonuclear leukocytes, sir.
Very good. Marked increase in. There is more than 50,000 leukocytes per deciliter, and more than 50% would be neutrophils. Please remember, if you can remember, this will be great. So marked neutrophilia. Most common joint involved in septic arthritis. There is a typo here, typographical error. Most common joint involved is
Hip, sir.
no, knee joint. Which of the following is an orthopedic emergency? Orthopedic emergency, no fracture is an emergency unless complicated with a vascular injury. Please remember this. No fracture is emergency unless associated with a vascular injury, or it is an open fracture, or it is a dislocation. Okay. So which of the following is orthopedic emergency? Intra-articular fracture, lateral condylar fracture, fracture neck of femur, septic arthritis. Anybody can take
Sir,
this.
fracture neck of the femur.
fracture neck of femur.
Fracture neck of the femur, sir.
Look at this. No. Septic arthritis is an emergency. Septic arthritis, every hour lost in treating septic arthritis, the joint gets irreparably damaged. Joint will end up not regaining any amount of movements. Every passing hour is a problem if you don't treat septic arthritis as an emergency. Septic arthritis is an emergency. Okay?
Excuse me, sir.
Of all the given options. If you ask me, if this option was not there, you can always consider fracture neck of femur. So you have to consider other options also. Understand?
Yes,
One
sir.
who answered fracture neck femur would have been right if there was no option of septic arthritis. Yes. Is there any doubt?
No,
Sir, I can understand, sir.
Okay, good. In case of suspected septic arthritis, best way to confirm the diagnosis? Well, again, it is a repeat kind of asking a question. Yes, very good. Tom Smith arthritis. Yes? Aspiration. I think we'll not waste time in that. Tom Smith arthritis is infectious arthritis destroying. Please read this question clearly. Having discussed earlier, I think most of you can answer this. Tom Smith arthritis is infectious arthritis destroying what?
Sir, epiphysis of femur, sir.
Very good. Okay, we'll not further discuss on this. All are true about septic arthritis except any most common cause of most common organism causing orthopedic infection. Please remember it
Staph
is
aureus.
always Staph aureus. Always. Most common organism in orthopedic infection is Staph aureus. Of course, in Salmonella is common in sickle cell or typhoid.
Yes,
Sickle
sir.
cell anemia or in typhoid.
Yes, sir.
In sickle cell disease, if there is osteomyelitis, you suspect Salmonella. Otherwise, in a normal or healthy individual, most common cause for orthopedic infection is Staph aureus across the age group. So, Staph aureus is common. Septic arthritis is common in children. Aspiration, we have discussed, it is common. So, this is except E. coli, right? Affects the growth plate. Certainly, it affects the growth plate. Non-healing sinus is a common clinical feature in a chronic osteomyelitis. Most common frequent cause for this presentation is, please read this. Non-healing sinus is a common clinical feature of a chronic osteomyelitis. Frequent cause for this is
Sir, sequestrum.
whether it very good. See, all are causes for non-healing sinus. All are causes for non-healing sinus in a chronic osteomyelitis, but most common is presence of a sequestrum. There can be retained body, there can be intraosseous cavity, there can be resistant organism, but most common cause is presence of sequestrum. Ideal treatment of acute osteomyelitis of long bone is, you can take this. See, it's so simple. You even if you don't have not read osteomyelitis, you can still answer this question.
Sir, antibiotics.
Yes. No. You read this options. There is antibiotics and if indicated decompression. Just antibiotics alone is not sufficient. Just decompression or drilling of the bone. Decompression, you please remember, in osteomyelitis, I'll just explain. Most commonly in a it affects your metaphyseal region, this part. I know you why it gets affected. So most important is, if there is a pus collection in this, you have to let it out. So any acute osteomyelitis, there is always a collection of the pus. You have to let it out. So that can be done by drilling of the holes in the bone. Drilling of the bone causes decompression. So it doesn't make sense to choose these two options. Antibiotics alone is not sufficient. So the best option is antibiotics if indicated decompression. Again, antibiotics only is possible if the patient, you see the patient within 24 hours of the infection. If the patient presents to you, just antibiotics might be sufficient, which covers the staph aureus. It might be sufficient, but always the generally patient comes after 24 hours. You might be keeping an option to drill the bone. Drilling of the bone is like drilling a bore in the site. You might end up water, you might not get water unless you heat the water level. But still decompression is essential. You let the pus out. Pus anywhere in the body, you have to let it out. Okay, installation treatment in osteomyelitis is continuous irrigation, continuous suction. Just go through the options. I'll explain that for you in a minute. Continuous suction, continuous drainage, continuous suction, intermittent drainage, intermittent suction, continuous drainage, intermittent suction, intermittent drainage. It doesn't make sense to choose these. Continuous suction and intermittent drainage doesn't make sense. Intermittent suction and continuous drainage means also doesn't make sense. It has to be continuous suction and continuous infusion, suction and drainage. It is not suction, there is a typo. Continuous instillation, or it is like this. I will draw a picture for you. In osteomyelitis, after having treated, you put one end of IV drip set and connect this to a bottle of antiseptic, especially most commonly iodized solution. So you continuously irrigate. It should be continuous irrigation and suction, or continuous irrigation and drainage. Okay, there has been a mistake in probably the options given, but one thing you remember, so it has to be continuous irrigation. You have to go continuously and you have to aspirate. So it can be suction or it can be drainage. So installation treatment in osteomyelitis is continuous suction and drainage. So drainage it cannot happen in gravity dependent. You have to connect this to a suction. You have to drain it. This installation is possible because of the height. You have to suck this continuously by a suction. True about HIV osteomyelitis is all except You have to read this. Osteomyelitis in HIV patients are similar to any osteomyelitis for the only reason that there is no newborn formation. In osteomyelitis, chronic osteomyelitis, and otherwise the non-seropositive individual, you will see a lot of newborn formation. Newborn formation is not seen in osteomyelitis in HIV patients. All are associated with chronic osteomyelitis except, you can answer this. Hello? You are
Yes,
there?
sir.
Anybody can answer this. It's a very
Sir,
simple question.
myositis ossificans,
Yes,
sir.
very good. This is not at all connected with chronic osteomyelitis. Most common complication is, sequestrum will be there. Amyloidosis, of course, is a rare complication, but it is always there associated with chronic osteomyelitis. Metastatic abscess can happen. 8-year-old boy presents with gradually progressing swelling, pain since 6 months over upper end tibia. On X-ray, there is a lytic lesion in upper tibial metaphysis. If you can answer this, I will explain for a while. Anybody? Please go through this. It will be more interactive.
Sir, Brody's abscess, sir.
Very good, very good. Brody's abscess. Osteomyelitis, you please remember, it can be acute, it can be subacute, or it can be chronic based on the duration. Acute is less than 2 weeks, subacute is 2 to 3 weeks, chronic is more than 3 weeks. Okay? Brody's abscess is one of the type of subacute. If there is no option for subacute, you can consider that as a chronic abscess, chronic osteomyelitis. One more important thing of, I'm not sure, let me see if there is a picture or no. There is no picture. Okay, Brody's abscess, most commonly seen in upper end tibia, very well contained cavity you can see, very well contained. How you know very well contained is, this is also called as sign if seen in MRI. If you see a very well contained cavity or a lytic lesion, you can always get confused for a cystic lesion. It can be simple bone cyst or it can be aneurysmal bone cyst. Aneurysmal means what? Ballooning or widening. If there is no widening of this bone, it can be simple bone cyst. You have to differentiate between simple bone cyst and Brody's abscess. Simple bone cyst, the wall will be very, very thin. It is also located in the metaphyseal region. But because of chronic infection, because of good host immunity, persistent infection is warded off. It is cordoned off by excessive newborn formation. Thick coverage of this cavity is hallmark of Brody's abscess. Okay, complications of osteomyelitis.
Chronicity.
Complications of osteomyelitis.
Chronicity.
Okay. Chronicity, fracture of, I think you can take multiple answer or
Septic chronicity.
only one.
Septic
Yes, sir.
chronicity.
Chronicity, sir.
Only chronicity. Can there be a fracture?
Maybe, sir.
Yes. Can there be infection, reactivation?
Yes, sir.
Yes. Can there be malignancy?
No, sir. No, sir.
No, sir.
It is malignancy only on, there is a rare complication, sinus tract malignancy is there, but it is very rare. All these are possible. I think there's a mistake in the question. Which of the following is not true regarding tubercular osteomyelitis? You can answer this. Secondary to TB, yes.
Yes, sir.
Inflammation is minimum, yes. Sequestrum is uncommon or periosteal reaction is seen. You know, one important thing you should understand for a periosteal reaction. What is periosteal reaction? I'll just explain this. This periosteum is elevated. If there is a pus getting collected, this periosteum gets elevated. Once periosteum is elevated, there is a new bone formation. Okay, this new bone formation is in the form of periosteal elevation. So if the periosteum has to get elevated, the virulence of the organism has to be really very high. Tuberculosis is known to be less virulent. It's a kind of a chronic subdued infection, you will see. So periosteal reaction is not seen as compared to pyogenic osteomyelitis. Sequestrum is uncommon. Yes, sequestrum is uncommon, but periosteal reaction is not seen compared to the extent what you see in pyogenic osteomyelitis. Post-surgical osteomyelitis, most common organism is, you can answer this having discussed in the past. Yes.
Staphylococcus.
Yes, staph. Most common organism causing infection in open fracture.
Same, sir.
Very
Same,
good.
sir.
Brody's, yes, very
Sir.
good. Brody's abscesses. Having discussed, you
Subacute
should be able to.
osteomyelitis.
Yes, very good. I have 1 or 2 more slides to go. I hope you are not tired. All are true about chronic osteomyelitis except review newborn form, reactive newborn formation. Involucrum is a dead bone. Cloaca is opening in the involucrum. Sequestrum is hard and porous. I hope at least 1 or 2 of you can answer this.
Sequestrum is not hard and porous. Sir. It is.
Sir, involucrum is reactive live bone, sir.
Very good. Very good. Involucrum is a live bone. It is a new bone surrounding a sequestrum. I have a picture here depicting very nicely. Look at this. There is a bone inside a cavity. This bone is a dead bone. This is a sequestrum. And all that new bone, see, normal bone are not so irregular. They are so very well defined bone, isn't it? There's a lot of new irregular bone surrounding this. So this is involucrum. Understand? The inside, what is sitting like a bird in a small nest is a sequestrum. And what is this? There is an opening, isn't it? Imagine a sequestrum. Imagine osteomyelitis like an inflated balloon. This is an involucrum. What is hanging is a kind of a glitter what you put in a birthday celebration. That is sequestrum. This is involucrum. So there has to be way out for a sequestrum, isn't it? That is opening called as cloaca. Okay? Am I clear? Just remember this analogy. It's very helpful for you to recollect. So there is a sequestrum like a glitter inside the balloons. There is the involucrum, which is wall of a balloon, which is live reactive bone, and for there has to be a way out for extrusion of the involucrum. This opening is called as cloaca. Okay. All are true about chronic osteomyelitis except, I mean, of course, I think there's a repeat. Okay. Repeat. Yeah. Post-traumatic osteomyelitis causing organism. Post-traumatic osteomyelitis causing organism. Of course, there's kind of a twist. There's nothing much. Staph aureus. Commonest cause of acute osteomyelitis. This you have to answer me. Commonest cause of acute osteomyelitis. Very good. Hematogenous. So, very good. Briefly, I will describe about your hematogenous osteomyelitis. So, blood vessels enter like this. There is a hairpin bend. So, why the metaphyseal region? Metaphyseal region is the most common site for a osteomyelitis. You must know this. It can appear in some other question. The reasons are plenty. One is hairpin bend of the blood vessels.
Yes, sir.
So sluggish blood
vascularity high.
So any patient, we will have some infection ongoing in the body, but because of good immunity, we overcome that. some amount of bacteremia, especially most commonly your tooth decay or any kind of bacteremia, here the blood flow is slow. So very likely chance that it can get lodged here. So hairpin bend vessels, slow or sluggish blood flow in the because of the hairpin bend vessels. Repeated trauma increase the blood flow. So bacteremia again and hairpin bend, and there is minimal phagocytosis. This one more reason why you have, because minimal phagocytosis because of reduced reticuloendothelial system. Okay, these are few reasons why most common site is metaphysis, and most common cause for osteomyelitis is hematogenous. Okay, broad is abscess. Well, I got the picture now. Well, we had described already, isn't it? Most common broad is abscess is terminology for in this option. Quickly will rush. Answer
Chronic
this.
osteomyelitis.
Chronic
Very
osteomyelitis.
good. Yes. Broad is abscess is a terminology. Well, again, it's a repeat. So, okay, we'll focus only on the X-rays. This is what I was mentioning. A very well localized lesion with the surrounding rim of sclerosis. It can be most commonly a Brody's abscess. There will be tenderness. Okay. Here again, you can see very well. This is a Brody's abscess. Because when the cavity comes closer to the periosteum, you will see this abnormal bone, new bone formation. This is not involucrum. This is irregular new bone formation because of elevation of the periosteum. Which of the following is not true regarding acute pyogenic osteomyelitis? Most common site is diaphysis of the bone. Most common cause is staph is correct.
First one.
Sequestrum is the newborn. Huh?
First one.
Sequestrum is a newborn. They are. Which of the following is not true? Okay.
First one, sir.
What is this? Sequestrum is a newborn formation surrounding the involucrum. This is wrong, isn't it?
Yes, sir.
Sequestrum is not a newborn.
Yes, sir.
Most common, of course, is metaphysis. I think the question must be wrong. But you will remember this fact. Most common is staph. Cloaca is again opening of the discharging sinuses. I think it must be except or not true. Diaphysis, of course, is not true. It is metaphysis. But this is also wrong. Sequestrum is not a newborn. Most common mode of infection is direct inoculation of trauma. No, it is a hematogenous spread.
Yes, sir.
Okay. Okay, that's all I have for today. Thank you, boys. If you have any particular issues to be addressed in orthopedics, you can give me a feedback going the way of the pattern or the way I'm trying to start discussion. You can give me feedback to Dr. Bilgi.
Yes,
Hello?
sir. Yes, sir.
So we
Yes,
can
sir.
improve. Will not waste a single minute because every time, every hour of your is precious for during your preparation. Okay.
Yes, sir.
Give me suggestion, give me feedback so that I will improvise in next. Or you have certain concerns. Of course, there cannot be a collective concern because it's a heterogeneous group. But individually, you can raise a concern. The common concern raised by you will try to address majority in the beginning, and individual concerns I'll take up in the end. Okay.
Okay, sir.
Thank you.
Thank you, sir.
Students, all of the students should try to participate. The newcomers join the class. Bacha. Others, I find them not participating. Only 2 are participating. Okay, you may leave the class now. Only except teachers. Rest of you can leave and we'll join tomorrow. There will be interstitial lung disease tomorrow at 8 o'clock. class. I'll be taking on interstitial lung diseases. Huh?
Thank you, sir.
Students can
Okay,
leave, except teachers. Students can. Okay.
Hello.
Students, all the students are left now. No,
Okay.
we are here now.
Umesh, are you recording?
Huh?
You are recording the presentation, isn't it?
Yeah, I will stop it now.
Okay.